Gobs of them. Okay, I just want to throw this up before I go into all the rest of the stuff. This is my schedule, but it shouldn't make any difference. If you're a Tuesday person, it's the same schedule. Okay, so you'll know today's our hospital orientation. Next week is cardiovascular assessment. Now that's going to be discussed in class on Thursday. So you're going to apply all your exceptional knowledge base that you're gaining between now and next Tuesday for cardiovascular assessment. Now, I'm trying to think how to say this. We have to fill out paperwork now if you're off your primary unit. You're doing that too?
You talk about the forms that the nurses sign?
Yes.
Yes.
We can't be with you. I can't be with 10 students. You can't be with. We can't be with 10 students at once if skills come up. I usually don't have anybody sign. My primary unit is 3B. Your primary unit is 4D on Tuesdays. So therefore, she can see what's going on 4D. I don't have the nurses on my primary unit sign the paper, but I especially have them in ED because I can't be in the ED, and ED is actually your skill opportunity unit. This is where you need to perfect your skills because this is, you know, the whole point is, how many of you started IVs second semester? Okay, this is pretty good in this group, half of you. That's a pretty exceptional number. But if you're in the ED, you maybe get 4, 5, 6 time opportunities while you're in the ED that day. I can't come down there. Sarah can't come down. Sorry, Miss Doolin. Better can't come to the ED every time for you to start an IV or put an NG tube in or put a Foley in. So we have to have the nurses now sign that they're willing to observe you doing that. And so I will be sending those papers, as they will, with you on your first assignment to an off unit. So cath lab, you usually don't get a lot of opportunity to do skills, but you may get, if I like you to follow, and we agree, you need to, when a patient comes in to the cath lab, you need to start with that, all the little things we do for a pre-cath, and sometimes that includes putting an IV in. So you would be at opportunity, so you need to have them sign that. You may get to do a 12 lead on a patient while you're down there. You may get a defibrillator patient while you're down there. You may get to do CPR on patients while you're down there. You may get you don't pronounce death, but you may be able to be there when they pronounce them dead. And that is the only unit where you come in dead and still get aggressive intervention. Okay, because that's very often. So the cath lab, I usually have them sign, even though they may not do anything but observe the whole day in the cath lab, but still I have them sign there. And that's the only 2 units I usually have them sign because I'm on the 3rd floor, which has the ICU, the CCU, and my base unit. Now, Miss Doolin's not going to be that lucky. She's not going to be by the ICU and the CCU. So the issue is she may have her students sign, or we may just be on an option where I'll check in if they need, and she'll do that for me, maybe on the D's.
I'm a bouncer. I like to go.
She is a bouncer. She's little, but she can get you.
Yeah. So I like to go around. Somebody actually put that on one of my evaluations. You jump around a lot. No kidding.
And I don't know that was positive.
Yeah.
Yeah.
Well, yeah.
It was?
Is.
Okay.
Because
In clinical.
Yeah, in clinical.
Okay.
Yeah.
In clinical, not in lecture.
So, no. You jump around a lot, but I do, and I like to go in every room, and I like to see where everybody is. So if you got me, I'll be around.
Just know we've got eyes watching you everywhere.
In the back of our heads.
The other thing, how many of you know, how many of you have been involved with hemodynamic monitoring? Not you, Sam. Okay, anybody ever take a blood pressure? That is hemodynamic monitoring. So hopefully all of you have been involved in that. And I don't know if even without an art line, it's still hemodynamic monitoring. Flow of blood, study of the flow of blood is hemodynamic monitoring. So blood pressures are, but the issue is this hospital, neither hospital does much in invasive hemodynamic monitoring. Now they do have art lines. So in critical care you may see that, but they don't use many PA catheters. That's kind of an out technology, at least in these 2 facilities. So, and actually I'll also include TJ in that. So if we're talking about the 3 facilities we use for this course, that is not likely. But you have obligations because there can be a couple questions on your NCLEX regarding hemodynamic monitoring. So there will be a lecture, and we will try to incorporate that information back. Basically with hemodynamic monitoring, what you need to know is how do I make sure it's accurate? Because who cares what a number is if it's not accurate? It's like even when I'm doing a blood pressure and I'm putting the wrong size cuff on the patient, guess what? I get a number, but the number's not accurate. So interpretation of that information is not acceptable.